Good evening and welcome to Dreamy Academy. Tonight we drift into a realm where the unseen becomes visible, where shadows reveal the architecture of life itself. As we begin, I'd love to know where you're watching from, your city, your country, perhaps even what the night sky looks like outside your window. If you enjoy these peaceful explorations of science, please take a moment to like the video and subscribe. It truly helps this little corner of quiet curiosity grow. To those already subscribed, thank you sincerely for being part of this slow and thoughtful adventure. Right now, as you listen, a vast, invisible symphony of energy washes over you. It passes through the walls, through your skin, through the very air you breathe, largely unnoticed. Our human senses, marvelous as they are, perceive only a sliver of reality's full spectrum. We see the vibrant hues of a sunset, feel the warmth of a fire, hear the rustle of leaves, but these are merely echoes, tiny vibrations in a much grander, silent ocean of energy. Imagine for a moment that your eyes could perceive the faint radio waves carrying distant conversations, or the microwaves gently warming your morning tea, or the ultraviolet light that paints flowers in patterns only insects can appreciate. What if you could see the very atoms that compose your hand shimmering with their own silent dances? This hidden mechanism, this constant unseen flow, holds within it profound beauty and a quiet truth. Reality is far richer, far more intricate than our immediate senses can grasp. Tonight, we embark on a journey to understand a corner of this invisible world, a corner that has transformed our ability to understand ourselves. We will explore the science of radiography, a practice that allows us to peer through the opaque, to witness the delicate structures within our bodies, to trace the quiet strength of bone and the soft contours of tissue. It is a science born of serendipity and refined by ingenuity, a practice that takes the deepest principles of physics and bends them to the service of healing and discovery. It is in essence a way of seeing that transcends the limitations of sight, revealing the intricate wonders hidden beneath the surface, deserving of our patient contemplation. What is light really, beyond the golden glow of a lamp or the deep blue of the sky at dusk? It is more than just what illuminates our world, more than the colours that dance before our eyes. Light is a messenger, an ancient traveller, carrying information across vast distances, from the heart of a distant star to the delicate sensors in your eyes. Yet the light we see, the visible spectrum, is but a slender thread in an infinitely larger tapestry, a vast shimmering ocean of energy known as the electromagnetic spectrum. Let's begin by considering this spectrum. Imagine it as a grand piano, stretching from one horizon to the next, with each key representing a different type of electromagnetic wave. Our human eyes can only perceive a tiny handful of keys in the very middle, the reds, oranges, yellows, greens, blues, and violets. To the left of these visible notes, the waves become longer, their vibration slower, their energy gentler. Here lie the radio waves that carry music and voices through the air, and the microwaves that warm our food. These waves pass through most materials with ease, rarely interacting with the dense structures of our world. They are the broad, slow swells on the ocean's surface. To the right, however, the waves grow shorter, their vibrations faster, their energy more intense. Beyond violet, we find ultraviolet light, the kind that gives us sunburns, invisible to us, but a vibrant beacon for bees. Further still, we encounter X-rays, and then gamma rays, the most energetic, the most penetrating. These are the sharp, rapid pulses, the deep, powerful currents that can cut through the very fabric of matter. Each of these waves, from the longest radio wave to the shortest gamma ray, is fundamentally the same phenomenon, a ripple in the electromagnetic field travelling at the speed of light. They differ only in their wavelength, the distance between successive crests, and their frequency, how many crests pass a point in a given time. And it is this difference, this exquisite variation in energy, that allows X-rays to unveil the hidden world within. Now, picture a single photon, a tiny packet of light energy. It is a peculiar thing, this photon, behaving sometimes like a wave spreading through space, and sometimes like a particle, a discrete entity. For our purposes, imagine X-ray photons as tiny energetic bullets, travelling at the speed of light. When a stream of these X-ray photons encounters matter, like the human body, several things can happen. Most of the photons might pass right through, continuing their journey unimpeded. This is called transmission. Some photons, however, might collide with the atoms in the matter, scattering off in a new direction. This is scattering. And crucially for radiography, some photons might be completely absorbed by the atoms, their energy transferred to the material. The key to radiography lies in this differential absorption. Not all materials absorb X-rays equally. Denser materials, or materials with a higher atomic number, meaning more protons and electrons in their atoms, are more effective at absorbing X-ray photons. Think of a thick, heavy curtain versus a sheer, delicate one. Visible light would be completely blocked by the thick curtain, but might pass through the sheer one. X-rays, on the other hand, might pass through the sheer curtain with barely a notice, but would be significantly attenuated, meaning many of their photons would be stopped by the thick, dense curtain. In the human body, bones are dense and contain calcium, an element with a relatively high atomic number. Soft tissues like muscle and fat are less dense and primarily composed of lighter elements like carbon, hydrogen, and oxygen. So when a beam of X-ray photons passes through a hand, for instance, many photons will sail straight through the soft flesh. But when they encounter the bones of the fingers and palm, a significant number of those photons will be absorbed. Fewer photons emerge from behind the bones. This creates a pattern, regions where many photons passed through, and regions where fewer photons passed through. It is in essence a sophisticated play of shadows. The denser structures cast a stronger shadow, while the less dense structures cast a fainter one. This beautiful principle allows us to create an image. If we place a detector, originally a photographic plate, now often a digital sensor, on the other side of the body, it records where the X-ray photons landed. Where many photons hit the detector, the image appears dark or bright, depending on the inversion. Where few photons hit, having been absorbed by bone, the image appears lighter or darker. The result is a two-dimensional shadow image, a map of the internal densities revealing the skeletal framework, the hidden contours of organs, and even the subtle presence of foreign objects. It is a profound extension of our vision, allowing us to see inside without incision, to diagnose ailments with a glance, and to marvel at the intricate architecture of the body that once lay entirely hidden. The discovery of X-rays by Wilhelm Conrad Röntgen in 1895 was not just a scientific breakthrough, it was a moment of pure wonder, an invitation to perceive a new dimension of reality. We have begun to glimpse the invisible spectrum to understand how certain energetic waves can pass through us, leaving a shadow map of our inner selves. But how, you might wonder, do we create these penetrating X-rays, these tiny energetic messengers, and how do we capture their fleeting shadows to form an image? This question of generation and capture, of harnessing the unseen, will guide our quiet exploration in the moments to come. Welcome back, dear friends, to the quiet, luminous halls of Dreamy Academy. As we stand at the threshold of Chapter 2, a gentle breeze of curiosity stirs, inviting us deeper into the invisible currents that shape our understanding of reality. In our last gathering, we marvelled at the very essence of X-rays, these tireless high-energy travellers of the electromagnetic spectrum, capable of weaving through the fabric of our physical forms, leaving behind a differential shadow map of our internal architecture. We spoke of their discovery, a pivotal moment that forever altered the landscape of medicine and our perception of the unseen. But now, a more profound question arises, one that beckons us to peer behind the curtain of their natural existence. How do we, with our human ingenuity, create these elusive X-rays? How do we harness such a potent form of energy, typically born from cosmic events or atomic decay, and bring it forth into a controlled environment, precisely when and where we need it? And once we've coaxed these invisible messengers into being, how do we then capture their fleeting whispers, their delicate dance of light and shadow, and translate them into the vivid, informative images that guide the healer's hand? This is where our journey truly begins to unfold, into the very heart of the X-ray machine itself. Imagine, if you will, a small unassuming glass vessel, an evacuated tube, often no larger than your forearm, yet within its quiet confines, a miniature cosmic drama unfolds. This, my friends, is the X-ray tube, the very engine of our radiographic exploration, a testament to human brilliance in bending the forces of nature to our will. At its core, the X-ray tube operates on a principle both elegant and powerful, the acceleration and sudden deceleration of electrons. Think of it as a meticulously choreographed atomic collision, designed to shed light, or rather X-rays, on the unseen. Let us explore its inner workings. Within this sealed, vacuum-packed glass envelope, two primary components stand in silent opposition, like distant stars in a tiny universe: the cathode and the anode. The cathode, our starting point, is a negative electrode, often housing a delicate coiled filament not unlike the one you might find in an old incandescent light bulb. When we send an electric current through this filament, it heats up, glowing with a soft, warm light. But this isn't just for show. This heat provides the energy to boil off electrons from the filament surface, a phenomenon known as thermionic emission. Picture countless tiny negatively charged particles, eager to escape, forming a cloud around the glowing wire, like moths drawn to a flame. These are our fundamental building blocks, the raw energy we will soon transform. Now, across the vacuum, standing ready to receive these eager travellers, is the anode. This is our positive electrode, typically a rotating disc made of a high melting point metal, most commonly tungsten, sometimes alloyed with rhenium. Tungsten, you see, is not chosen by accident. It possesses a remarkably high atomic number, meaning its atoms have many protons and electrons, and it can withstand immense heat, qualities crucial for the intense drama about to unfold. Between this electron-emitting cathode and the waiting anode, we apply an incredibly high voltage, a potent electrical potential difference. Think of it as creating an irresistible magnetic pull, a powerful force field. This immense voltage acts like a cosmic slingshot, propelling those boiled-off electrons from the cathode towards the positively charged anode with breathtaking speed. They don't just drift, they accelerate, reaching velocities that are a significant fraction of the speed of light, hurtling across the vacuum with a singular purpose. And then, the moment of impact. These high-speed electrons, now imbued with tremendous kinetic energy, slam into the target surface of the anode. What happens next is the magic, the very genesis of our X-rays. When these rapidly moving electrons collide with the tungsten atoms of the anode, two primary types of interactions occur, both leading to the production of X-rays. One, Bremsstrahlung radiation, breaking radiation. This is the more prevalent mechanism. Imagine our high-speed electron hurtling towards a tungsten atom. As it approaches the positively charged nucleus of the tungsten atom, it experiences a powerful electrostatic force. This force causes the electron to suddenly slow down, to brake or change direction. And just as a car skidding to a halt dissipates energy as heat and sound, our electron, in its sudden deceleration, releases its excess kinetic energy in the form of an X-ray photon. The closer the electron gets to the nucleus, the more dramatically it's affected, and the higher the energy of the X-ray photon produced. It's a continuous spectrum of X-ray energies, a symphony of light born from deceleration. 2. Characteristic radiation. Sometimes our incoming electron doesn't just break, but instead collides directly with an electron in one of the inner shells of a tungsten atom, knocking it out of its orbit. This leaves a temporary hole in the electron shell, an unstable vacancy. To restore stability, an electron from an outer shell immediately drops down to fill that inner shell vacancy. As it does so, it releases a very specific, discrete amount of energy, an X-ray photon with an energy characteristic of the difference between those electron shell energy levels in tungsten. These are like the unique musical notes of the tungsten atom itself. The vast majority of the energy, over 99%, from this electron collision, however, is not converted into X-rays. It's transformed into heat. This is why the anode is often designed to rotate, spinning rapidly during exposure. This rotation ensures that the electron beam continuously strikes a fresh, cooler surface of the anode, preventing it from overheating and melting. Imagine the immense heat generated by millions of electrons slamming into a tiny spot every second. The rotating anode, along with cooling systems, is a vital safeguard, ensuring the X-ray tube's longevity and performance. So from this controlled dance of electrons within a vacuum, we generate our invisible X-ray beam. The energy and intensity of this beam are precisely controlled by the voltage applied, which dictates the speed of the electrons and thus the energy of the X-rays produced, known as kVp or kilovoltage peak, and the current flowing through the filament, which determines the number of electrons boiled off and thus the quantity of X-rays produced, known as mAh or milliampere seconds. This exquisite control allows us to tailor the X-ray beam to the specific task at hand, whether it's imaging a delicate hand or a dense spine. Now that we have successfully conjured these penetrating rays, our next challenge emerges. How do we capture their ephemeral message? How do we take these invisible shadows, these subtle variations in transmission, and render them visible, tangible, and interpretable? This brings us to the fascinating world of X-ray detection and image formation. Recall from Chapter 1 that as the X-ray beam traverses the human body, it undergoes differential absorption. Dense structures like bone absorb more X-rays, while less dense tissues like muscle and fat allow more X-rays to pass through. The X-rays that do transmit through the body carry a precise imprint of its internal architecture, a grayscale map of its densities. Our task now is to record this map. In the early days, immediately following Röntgen's discovery, the primary method of capturing these shadows was surprisingly simple: photographic film. Imagine a sheet of specialized film, much like the film used in traditional cameras, but far more sensitive to X-rays than to visible light. This film is typically sandwiched between two intensifying screens, which contain phosphors. When X-rays hit these phosphors, they emit visible light, and it's this visible light that primarily exposes the film. Where more X-rays passed through the body, e.g. through soft tissue, more light would be emitted by the screens, leading to a darker area on the developed film. Conversely, where fewer X-rays penetrated, e.g. through bone, less light would expose the film, resulting in a lighter or whiter area. After chemical processing in a darkroom, much like developing a photograph, the invisible X-ray pattern would magically appear as a tangible two-dimensional image, a negative of the body's internal structure. This was the fundamental principle, a physical recording of differential absorption. While film radiography served us faithfully for many decades, our journey into the digital age has revolutionized X-ray imaging, offering unprecedented clarity, flexibility, and efficiency. Today, the vast majority of X-ray images are captured using digital detectors. Let's explore the two main categories of digital radiography. 1. Computed radiography, CR. Think of CR as a bridge between film and true digital imaging. Instead of film, we use special photostimulable phosphor plates, PSP plates, often housed in cassettes similar to film cassettes. When X-rays strike these plates, the phosphor crystals within them store the energy from the X-ray photons, rather than immediately emitting light. After the exposure, the cassette is placed into a special reader. Inside the reader, a laser scans the plate, causing the stored energy to be released as light, a process called photostimulated luminescence. This emitted light is then captured by a photomultiplier tube, converted into an electrical signal, and finally digitized to form the image. The plate can then be erased and reused. It's like writing with light and then reading it with a laser. 2. Digital radiography, DR. This represents the cutting edge, offering immediate image acquisition. DR systems use flat panel detectors that can be broadly categorized into two types. Indirect conversion detectors. Here, the X-ray photons first strike about a scintillator layer, often made of cesium iodide or gadolinium oxysulfide. The scintillator absorbs the X-rays and converts their energy into visible light. This light is then captured by an array of photodiodes, a thin film transistor or TFT array, which convert the light into an electrical charge. This charge is then digitized to form the image. It's a two-step process: X-rays to light, then light to electrical signal. Direct conversion detectors. These detectors are even more direct. X-ray photons directly interact with a photoconductor material, such as amorphous selenium. This material immediately converts the X-ray energy into an electrical charge, without an intermediate light conversion step. This charge is then collected by the TFT array and digitized. This one-step conversion often leads to even sharper images. Regardless of the specific digital technology, the outcome is the same. The variable intensity of the X-ray beam transmitted through the patient is converted into a digital electrical signal. This signal is then processed by a computer, which assigns a grayscale value to each tiny point or pixel in the image. Areas where many X-rays passed through, less dense tissue, will correspond to higher pixel values, often displayed as darker shades on a digital monitor. Areas where few X-rays passed through, denser tissue like bone, will correspond to lower pixel values, displayed as lighter or whiter shades. And there it is, friends, the invisible made visible. From the precise generation of X-rays within a vacuum tube, through their careful journey through the human form to their capture by sophisticated digital detectors, we transform energy into information. This digital image, unlike film, can be viewed instantly, enhanced, manipulated for optimal contrast and brightness, stored electronically and shared seamlessly across vast distances. It's a testament to how far we've come from Röntgen's initial serendipitous discovery. We've explored the very heart of the X-ray machine, witnessing the controlled dance of electron that brings forth these invisible rays, and then delved into the ingenious methods by which their nuanced shadows are captured and translated into the vivid, grayscale maps of our inner selves. This journey, from the ethereal concept of differential absorption to the tangible clarity of a radiographic image, truly illustrates our capacity to extend our senses, to understand the profound beauty hidden within the fabric of our own existence. As we conclude this chapter, take a moment to appreciate this intricate ballet of physics and engineering. It is through such precise and thoughtful applications of scientific principles that we gain the power to peer beneath the surface, to diagnose, to heal, and to continue our endless quest for understanding. In our next session, we will begin to interpret these images, to understand the language of shadows and light, and to truly see what the X-ray reveals. Until then, let your curiosity be your guide, and may your dreams be filled with the quiet wonder of the unseen. In our last quiet gathering, we journeyed into the heart of the X-ray tube, witnessing the elegant ballet of electrons transforming into invisible waves, and then, with equal grace, we saw these waves captured, etched onto digital canvases. We learned how the unseen becomes visible, how the internal landscapes of our bodies are momentarily unveiled for our study. But now, with these luminous images before us, a new and profound question arises, doesn't it? What do they mean? How do we translate these intricate patterns of light and shadow into understanding, into knowledge, into the quiet truths they hold? This, my dear friends, is where our adventure truly deepens. We are no longer merely observing the creation of a map. We are learning to read its ancient, intricate script. We are stepping into the realm of interpretation, where the subtle interplay of tones and textures whispers stories of health and illness, structure and function. It is a language spoken not in words, but in the eloquent silence of varying densities, of visual poetry that demands our patient contemplation. Imagine, if you will, the X-ray image not as a simple photograph, but as a vast monochromatic symphony, played out across a spectrum of greys, from the deepest velvety blacks to the most brilliant ethereal whites. Every shade tells a part of the story. This spectrum, this nuanced scale of luminosity, is born from the fundamental principle we touched upon in our very first chapter: differential absorption. Recall how X-rays, those tireless travellers, interact with the matter they encounter. May pass through almost unimpeded, while others are absorbed, their energy taken up by the atoms within the tissues. It is this varied interaction that paints our image. Consider the air within our lungs, or the pockets of gas in our intestines. These are regions of very low density containing few atoms to interact with the X-ray photons. Here the X-rays encounter little resistance. They sail through, largely unscattered and unabsorbed, reaching the detector in great numbers. On our image, these areas appear as the darkest shades, often pure black. We call these regions radiolucent, meaning literally transparent to radiation. They are the empty spaces, the airy expanses, the voids that allow light to pass. Now shift your gaze to the other end of the spectrum. Think of the dense mineralized architecture of our bones. Here, calcium and phosphorus atoms stand as formidable guardians, eagerly absorbing and scattering a significant portion of the incoming X-ray photons. Fewer X-rays manage to penetrate these structures and reach the detector. Consequently, these areas register as the brightest shades on our image, often brilliant white. These are radiopaque, opaque to radiation. Bones, but also any metallic implants, surgical clips, or even foreign objects, will shine with this stark luminosity, proclaiming their density with an unmistakable brilliance. Between these two extremes, the radiolucent black of air and the radiopaque white of bone, lies the vast, subtle realm of grey. This is where the soft tissues reside: muscles, organs, fat and fluids. Each possesses its own unique atomic composition and density, absorbing X-rays to varying degrees. Fat being less dense than muscle will appear a darker grey. Muscle and fluid with their higher water content will present as slightly brighter intermediate greys. It's a delicate dance of absorption, where every tissue casts its own unique shadow, contributing to the rich tapestry of the image. So that when we look at an X-ray, we are essentially interpreting a shadow map of densities. Black means low density, air. White means high density, bone, metal. And the myriad shades of grey in between reveal the soft tissues. This understanding forms the very bedrock of radiographic interpretation, but merely perceiving these differences in density is only the beginning. To truly read the story, we must also appreciate the concept of contrast. The contrast, in essence, is the difference in brightness between adjacent structures on our image. Imagine a painting where all the colours are muted, blending into one another. It would be difficult to discern individual forms. Now, imagine a painting with vivid, distinct colours, where every line and shape stands out clearly. This is the power of contrast. In radiography, good contrast allows us to differentiate between tissues that have only subtle differences in X-ray absorption. Without sufficient contrast, a tumour nestled within soft tissue might blend indistinguishably with the surrounding healthy structures, lost in a monochrome haze. The quality of our contrast is influenced by several factors, most notably the kilovoltage peak, kP, we discussed earlier. Higher kVp settings, with their more penetrating X-rays, tend to produce images with lower contrast, meaning more shades of grey and less distinction between very bright and very dark areas. Lower kVp settings, conversely, often yield higher contrast images, with more pronounced differences between black and white, making them ideal for visualizing bone. Mastering this balance is an art, allowing us to tailor the image to the specific diagnostic question at hand. Beyond density and contrast, the clarity with which we perceive fine details is paramount. This brings us to a spatial resolution, often simply called detail. Resolution is our ability to distinguish between two very small, closely spaced objects as separate entities. Think of looking at a photograph. A high-resolution image allows you to see individual strands of hair or the intricate patterns on a leaf, while a low-resolution image might blur these into an indistinct mass. In radiography, achieving exquisite spatial resolution means minimizing anything that blurs or degrades the image. Factors like the size of the X-ray tube's focal spot, the area on the anode where electrons strike, the distance between the X-ray source and the detector, source-to-image distance or SSID, and the distance between the object and the detector, object-to-image distance or OID, all play critical roles. A smaller focal spot acts like a finer brush, creating sharper shadows. A greater psi E reduces beam divergence, leading to less geometric unsharpness, and minimizing AE ensures the object's shadow is cast as crisply as possible onto the detector, much like holding your hand closer to a light source to get a sharper shadow on the wall. Every millimeter matters when we seek to reveal the most minute anatomical features. As we delve deeper into this visual language, we must also acknowledge the inherent challenges of translating a three-dimensional reality onto a two-dimensional surface. This introduces the concept of distortion. When we project a complex volumetric structure onto a flat plane, certain alterations inevitably occur. The most common form is magnification, where the object appears larger on the image than its actual size. This magnification is greater the further the object is from the detector, larger OID, and the closer it is to the X-ray source. Imagine holding a small object close to a flashlight and casting its shadow on a distant wall. The shadow appears much larger. Radiographers meticulously position patients and equipment to minimize magnification, bringing the area of interest as close to the detector as safely possible. Another form of distortion is shape distortion, where the object's true form is altered, appearing elongated or foreshortened. This occurs when the object is not perfectly parallel to the detector, or when the X-ray beam is angled inappropriately. A perfectly round coin, if tilted relative to the X-ray beam, might appear elliptical on the image. Understanding and minimizing distortion is crucial for accurate diagnosis, as an abnormally shaped organ could be misinterpreted if its altered appearance is merely a projection artifact. Perhaps the most significant challenge in interpreting these two-dimensional images of a three-dimensional world is imposition. When X-rays pass through the body, all the structures along the path of the beam are projected onto the same plane. Bones can overlay organs, vessels can cross paths with soft tissues, and healthy structures can obscure pathology. It's like looking at a dense forest from directly above. All the trees blend into a single canopy, making it difficult to discern individual trunks or paths beneath. To overcome the inherent limitations of superimposition, we frequently acquire multiple views of the same anatomical region, for instance a frontal anterior-posterior or posterior-anterior view and a lateral side view. By examining the anatomy from different angles, we can mentally unravel the superimposed structures, gaining a more comprehensive spatial understanding. A lesion that is hidden behind a rib on a frontal view might become clearly visible when viewed from the side. This triangulation of information is fundamental to accurate interpretation, allowing us to mentally reconstruct the three-dimensional reality from its two-dimensional projections. So what, then, is the grand secret to mastering this language of light and shadow? It is not merely about memorizing patterns, though recognition of normal anatomy is, of course, essential. It is about cultivating a discerning eye, a thoughtful mind, and a deep appreciation for the underlying physics that creates these images. It is about systematically approaching each image, asking questions: where is the air, where is the bone, what are the relative densities of the soft tissues, are there any unexpected radiopacities or radiolucencies, is the contrast adequate, are the details sharp, is there any distortion or superimposition that might be misleading? This journey into interpretation is a continuous learning process, a blending of scientific knowledge with a keen sense of observation. It requires us to slow down, to truly see what is before us, and to allow the image to reveal its quiet truths. We are learning to perceive the unseen, to understand the intricate workings within, and to appreciate the profound elegance of how physics allows us this glimpse. As we conclude this chapter, I invite you to carry this newfound understanding with you. Look at the world around you and imagine the hidden densities within. Ponder how light interacts with objects and how shadows are cast. For in every interaction of energy and matter, there is a fundamental principle of radiography at play, a silent lesson waiting to be discovered. In our next exploration, we will begin to apply this language to specific anatomical regions, learning to identify the normal, and thus to recognize the deviations that whisper of the abnormal. The adventure continues, ever more wondrous, ever more insightful. Welcome back, dear friends, to the gentle embrace of Dreamy Academy. We journey onward, ever deeper into the luminous heart of medical imaging science, our minds alight with curiosity, and our spirits attuned to the profound beauty of discovery. In our last contemplative session, we began to decipher the subtle language of light and shadow, learning to distinguish the whispered tales told by radiolucent air from the bold pronouncements of radiopaque bone. We understood that each shade of grey, each variance in brightness, was a direct echo of density, a testament to the varying ways the body's intricate tapestry interacts with the penetrating gaze of X-rays. Now, as we stand on the threshold of this new exploration, we carry with us the understanding that these images, these two-dimensional maps, are more than mere patterns. They are portraits of the human form, rendered in an invisible light, awaiting our careful interpretation. We've learned the alphabet, the grammar, and even a few complex sentence structures of this visual language. Today we begin to read the grand narrative itself, the story of human anatomy as revealed through radiography. Imagine, if you will, that we have just received a complex, exquisitely detailed map. We know how to read the legend, how to discern mountains from valleys, rivers from roads. But to truly navigate, to understand the meaning of the landscape, we must first orient ourselves. We must understand the cardinal directions, the conventions by which the map was drawn. This, my friends, is precisely what we must do with the human body in the context of radiography. The human body is a magnificent three-dimensional sculpture, yet our X-ray images, as we've discussed, are two-dimensional projections. To bridge this dimensional gap, to ensure we are all speaking the same anatomical language, we rely on a universal standard, the anatomical position. Picture a person standing upright, feet together, arms at their sides, palms facing forward, and eyes looking straight ahead. This seemingly simple stance is our reference point, the zero coordinate from which all directions and relationships within the body are universally understood. From this position, we define planes that slice through the body, revealing its internal architecture. Consider the sagittal plane, which divides the body vertically into right and left portions. A mid-sagittal plane would split us perfectly down the middle, creating two symmetrical halves. Then there's the coronal plane, also vertical, which divides the body into anterior, front, and posterior back sections. And finally, the transverse plane, a horizontal cut that separates the body into superior upper and inferior lower parts. These imaginary planes are not just academic constructs. They are the fundamental frameworks that allow us to precisely describe the location of structures and, critically, to understand the orientation of our radiographic images. When we speak of an X-ray taken in a lateral view, for instance, we are inherently referencing a projection along one of these planes, revealing a specific profile of the body. This brings us to the very heart of applying our knowledge: radiographic projections. In Chapter 3, we touched upon the necessity of acquiring multiple views to overcome the challenge of superimposition, that perplexing phenomenon where structures overlap, obscuring vital details. Now, let us explore the common projections, the standard angles from which we view the body, each designed to highlight different aspects of its internal landscape. The most common projections often relate to the direction the X-ray beam travels through the patient. An anterior-posterior AP projection means the X-ray beam enters the anterior front surface of the body and exits the posterior back surface, striking the detector. Imagine standing facing the X-ray tube. Conversely, a posterior-anterior PA projection has the beam entering the sage posterior and exiting the anterior, striking the detector. Here, you would be standing with your back to the X-ray tube. For chest X-rays, the PA view is often preferred because it minimizes the magnification of the heart, making it appear closer to its true size. Then we have this lateral projection, where the beam enters one side of the body and exits the other. This view is invaluable for visualizing structures that would be superimposed in an AP or PA view. Think of a simple chest X-ray. An AP view shows the heart and lungs, but a lateral view reveals the space behind the heart and the true depth of the chest cavity, crucial for detecting subtle abnormalities. And finally, the oblique projections. These are views taken at an angle, somewhere between a true APPA and a true lateral. They are the artistic flourishes of radiography, allowing us to unroll or separate superimposed structures, revealing hidden facets. Imagine needing to see a specific joint or a complex bone structure from an angle that doesn't fit neatly into the cardinal planes. Oblique views are our answer, offering a nuanced perspective that often unlocks diagnostic certainty. Each projection serves a distinct purpose, a deliberate choice made by the radiographer to best demonstrate the anatomy of interest. It's not arbitrary, it's a thoughtful process, a skilled dance between patient, X-ray tube and detector, all orchestrated to capture the clearest possible image. This is where the art of patient positioning truly shines. A slight rotation, a subtle tilt, a careful adjustment of the patient's breathing, these seemingly small details can dramatically impact image quality and diagnostic utility. A perfectly positioned patient is paramount for an accurate diagnosis, ensuring that the structures are not only visible, but also presented in their true anatomical relationships, free from unnecessary distortion or superimposition. Now, with our anatomical compass set and our understanding of projections in hand, let us revisit the language of tissues, but this time with specific anatomical examples. We learned about the 5 basic radiographic densities: air, fat, water, and soft tissue, bone and metal. Let us see how these manifest within the living architecture of the human form. Air. The least dense appears black or very dark grey on our images. Where do we find it in the body? Most prominently within the lungs, which are essentially vast sacs of air interwoven with delicate tissues. We also see air in the trachea and bronchi, the airways leading to the lungs, and often within the bowel loops of the digestive system. The presence or absence of air in these areas, or its appearance in places it shouldn't be, like the abdominal cavity outside the bowel, tells us a great deal. Next, which appears a darker shade of grey, slightly brighter than air. The human body is rich in fat, cushioning organs, providing insulation and storing energy. On an X-ray we might see it as subtle dark grey lines or regions surrounding muscles or organs, such as the fat pads around joints or the subcutaneous fat just beneath the skin. Its presence can sometimes delineate the borders of soft tissue structures more clearly. Then we have sea water, or more accurately, which includes muscles, organs like the heart, liver, kidneys, blood vessels, and fluids. These structures all have a similar density, appearing in various shades of lighter grey. Differentiating between specific soft tissue organs on a plain X-ray can be challenging due to their similar densities and the effects of superimposition. This is where the skill of interpretation truly comes into play, discerning subtle changes in contour or density that might indicate pathology. Bone. With its dense, calcified matrix, stands out as brilliantly white or very light grey. The entire skeletal system, the bones of the skull, spine, ribs, pelvis, and limbs, forms the radiopaque scaffolding of the body, clearly visible and easily identifiable. Fractures, dislocations, and degenerative changes in bone are often readily apparent due to this high contrast. Finally, metal, the most radiopaque, appears as the brightest white, often almost glowing on the image. This can be anything from surgical implants, screws, plates, prostheses, to foreign bodies, bullets, swallowed objects, or even contrast agents containing heavy elements. Its stark appearance is unmistakable and often serves as a valuable landmark or indicator of intervention. To bring all these concepts together, let us take a first glimpse at a common radiographic study, the chest X-ray. This single image is a symphony of densities, a testament to the power of differential absorption. Imagine a PA chest X-ray. We immediately see the dazzling white of the ribs, the core clavicles, and the core thoracic spine, the bones of the chest, clear and distinct. Within this bony cage, the key lungs appear predominantly dark, almost black, due to the vast amount of air they contain. We can trace the branching patterns of the bronchi and the subtle outlines of the larger pulmonary vessels as they course through this airy landscape, appearing as delicate grey lines. Nestled in the centre, slightly to the left, we observe the soft tissue density of the heart and great vessels, aorta, vena cava, appearing as a homogeneous lighter grey shadow. Its borders are usually distinct against the darker lung fields. Beneath the lungs on either side we see the dome-shaped shadows of the diaphragm, the muscular partition separating the chest from the abdomen, also appearing as soft tissue grey. Below the diaphragm we might glimpse the liver shadow on the right and the stomach bubble, containing air, on the left, offering clues about the upper abdominal organs. A skilled radiographer with a deep understanding of anatomy and positioning ensures that this complex interplay of shadows is captured with precision. They select the appropriate projection, PA and lateral as standard for chest, guide the patient to hold their breath at the peak of inspiration, to inflate the lungs fully, making them darker and pushing the diaphragm down, and ensure the patient is straight and still. Any deviation, a rotated patient, an incomplete inspiration, patient movement, can introduce artifacts or obscure vital information, rendering the image non-diagnostic. This delicate balance between technical skill, anatomical knowledge, and patient interaction is what elevates radiography from a mere technical procedure to a vital diagnostic art form. As we conclude this chapter, we have taken a significant step forward. We've moved beyond merely understanding how X-rays work and how to interpret their basic visual language to truly beginning to read the story they tell about the human body. We've established our anatomical compass, explored the various perspectives offered by different projections, and applied our knowledge of tissue densities to the living canvas. Our journey through the human form as seen through the X-ray's silent gaze is just beginning. In the chapters to come, we will systematically explore specific regions of the body, the intricate dance of the skeletal system, the delicate balance of the respiratory tree, the complex pathways of the digestive system, applying the principles we've so carefully cultivated. Each new region will present its own unique challenges and its own profound beauty, inviting us to look closer, to understand deeper, and to appreciate the quiet truths revealed by the invisible light. Until then, my friends, carry these insights with you and let your curiosity continue to guide your thoughtful adventure. Welcome back, my friends, to our quiet sanctuary within the Dreamy Academy. We left off last time contemplating the elegance of a chest X-ray, that fundamental window into the intricate dance of breath and beat. We saw how air, bone, and soft tissue painted their distinct portraits, each shade a whisper of density. But the human body, as you know, is a vast and wondrous continent, far richer and more varied than a single landscape can convey. Today we embark on a deeper expedition, an anatomical odyssey through the body's principal regions, learning to read the specific tales told by X-ray images from head to toe. Each area presents its own unique challenges and revelations, a distinct dialect within the broader language of light and shadow we've been so patiently learning. As we journey, I invite you to imagine yourself not merely as an observer, but as an explorer, a cartographer of the unseen, meticulously mapping the delicate balance of form and function. Let us first return to the familiar embrace of the thorax, that protective cage housing life's most vital rhythms. We saw its basic architecture, but now let's lean closer, discerning the finer details. The lungs, those magnificent airy sacs, appear as predominantly dark radiolucent fields, a testament to their air-filled nature. Within this darkness, you'll notice a delicate lacework of branching lighter lines. These are the pulmonary vascular markings, representing blood vessels bringing life to and from the lung tissue. Observe their gradual tapering as they extend outwards, a normal finding. When disease strikes, these patterns can change dramatically. Imagine a pneumonia, for instance, where infection fills the air sacs with fluid and inflammatory cells. On an X-ray, this appears as a localized patch of increased whiteness and opacity, obscuring the normal vascular markings, like a cloud obscuring a starry night. Similarly, if fluid accumulates in the pleural space surrounding the lungs, known as a pleural effusion, it tends to pool in the lowest parts, often blunting the normally sharp angles where the diaphragm meets the ribs, the costophrenic angles. It's a subtle but crucial sign, a pooling shadow that hints at an underlying issue. Nestled between these airy expanses, we find the heart and mediastinum. The heart, a tireless muscle, presents as a smooth, rounded, soft tissue density, its silhouette typically occupying the left side of the chest, often extending slightly to the right. The mediastinum itself is the central compartment of the chest, containing the heart, great vessels, trachea and esophagus. On a standard PA posterior-anterior chest X-ray, the heart size and shape are evaluated. If it appears enlarged or shifted, it can indicate a host of conditions, from heart failure to masses pushing it aside. Remember our discussion in Chapter 4 about the PA projection minimizing magnification of the heart. This is precisely why it's preferred for cardiac evaluation, offering a truer reflection of its dimensions. And then there are the bony structures of the thorax, the ribs, the clavicles, the scapulae. These appear strikingly white, their dense calcium structure absorbing X-rays with great efficiency. We meticulously trace each rib, searching for any disruption in its smooth contour, a telltale sign of a fracture. Sometimes a fracture can be subtle, a hairline crack, demanding a keen eye and thoughtful contemplation. The diaphragm, that muscular sheet separating the chest from the abdomen, appears as two smooth, domed soft tissue densities, typically higher on the right side due to the liver beneath it. A truly critical finding here would be the presence of free air beneath the diaphragm, a dark crescent-shaped lucency, often indicating a perforation of an abdominal organ. It's a silent alarm, demanding immediate attention. Moving downwards, we enter the realm of the abdomen, a region that presents a distinctly different radiographic challenge. Unlike the chest, which offers the stark contrast between air-filled lungs and dense bone, the abdomen is largely composed of soft tissues and fluid-filled organs, all of similar density. This means the inherent contrast is much lower, and we must rely on more subtle cues, the patterns of gas, the outlines of fat planes, and the contours of solid organs. Our standard views for the abdomen typically include an AP supine projection, often affectionately called a KUB for kidneys, ureters and bladder, and an erect abdomen view. The erect view is crucial for detecting air fluid levels within the bowel, or, more critically, free air in the peritoneal cavity, which would rise to the highest point under the diaphragm. What do we look for? First, the patterns of bowel gas. A small amount of gas is normal in the stomach and a large intestine. However, abnormally dilated loops of bowel, especially in a ladder-like configuration, can signal a bowel obstruction. We also look for the faint kidney bean-shaped outlines of the kidneys, sometimes visible just lateral to the lumbar spine, and the smooth linear shadows of the psoas muscles which flank the lumbar vertebrae. These muscle outlines can be obscured in cases of inflammation or fluid accumulation. The large homogeneous soft tissue densities of the liver, on the right, and spleen, on the left, are also part of this subtle landscape. The abdomen is a canvas where we search for the abnormal amidst the normal, like reading an ancient palimpsest where faint erased texts might still hold vital clues, a tiny crescent-shaped lucency of free air, a dilated loop of bowel, or an unusual calcification. Each is a breadcrumb leading us towards a diagnosis. Now let us turn our gaze to the extremities, the arms, legs, hands and feet. Here the task of radiography often feels more straightforward, thanks to the remarkable contrast between dense bone and the surrounding soft tissues. This high contrast makes the extremities an ideal subject for X-ray imaging, primarily for detecting gut fractures, assessing our joint alignment, and identifying degenerative changes like arthritis. The golden rule for extremity radiography is to obtain a minimum of 2 orthogonal views, meaning projections taken at 90 degrees to each other, typically an AP and a lateral. Why 2? Because a fracture might be perfectly aligned and invisible on one view, but clearly displaced and obvious on another. Imagine trying to describe a 3-dimensional object by only looking at its shadow from a single angle. You'd miss so much. For more complex joints or areas like the hand and foot, oblique views are often added to unfold the intricate anatomy and separate overlapping structures. When we examine a long bone like the femur, tibia or humerus, we scrutinize the dense white cortical bone for any disruption in its smooth continuous line. A fracture appears as a dark, often jagged, line traversing this white expanse. We assess its location, its type, transverse, oblique, spiral, or and any displacement or angulation of the bone fragments. The lighter grey of the medullary cavities within the bone also offers context. For our joints, like the knee, ankle, or wrist, we meticulously evaluate the joint spaces, the smooth, articular surfaces of the bones and their overall alignment. Narrowing of the joint space, the presence of bony spurs, osteophytes, or irregular bone surfaces can all point to arthritis or other degenerative processes. The radiographer's skill in positioning is paramount here. A slight rotation can project a fracture line in an unfavourable way, making it less conspicuous. Precise centering and angulation of the X-ray beam ensure that the anatomy is presented without unnecessary distortion, allowing the subtle story of the bone and joint to be clearly told. The spine. That magnificent segmented column that supports us is a region of both incredible strength and intricate vulnerability, comprising the cervical, thoracic, and lumbar vertebrae, along with the fused bones of the sacrum and coccyx. It is a complex structure to image due to its natural curves and the overlapping shadows of other body parts, ribs, pelvis, shoulders. For the spine, multiple views are almost always necessary. We use AP and lateral views to assess the vertebral bodies, disc spaces, and overall alignment. For specific regions, oblique views are crucial. For example, in the cervical spine, oblique projections help visualize the neural foramina, the small openings through which nerves exit the spinal cord, checking for any narrowing that might impinge on these delicate structures. In the lumbar spine, oblique views can reveal the facet joints, which are often implicated in back pain. We look for signs of trauma, fractures of the vertebral bodies or their processes, dislocations or subluxations. We also search for degenerative changes, such as disc space narrowing, osteophyte formation, or changes in the alignment suggestive of spondylolisthesis, a slippage of one vertebra over another. Scoliosis. An abnormal curvature of the spine is also beautifully demonstrated on plain X-rays, allowing for measurement and monitoring. The spine, in its radiographic depiction, is a testament to the body's engineering, but also a silent narrator of the stresses and strains it endures. Finally, let us consider the whole skull. That intricate bony fortress protecting our most vital organ. Historically, plain X-rays of the skull were a primary tool for assessing head trauma, searching for fractures. Views like the AP, lateral, Townes, and Waters projections were commonly employed, each designed to highlight different regions and minimize superimposition from the numerous overlapping bones, sutures, and sinuses. However, the skull is a challenging area for conventional radiography. Its complex curvilinear surfaces and the sheer number of overlapping structures mean that many areas are inherently obscured. More importantly, plain X-rays are excellent for bone, but they tell us very little about the soft tissues within the skull, the brain itself. Subtle intracranial bleeds, contusions, or tumours, which are often the most critical findings in head trauma or neurological conditions, are largely invisible on plain X-rays. For this reason, plain skull X-rays have largely been superseded by more advanced imaging modalities, particularly computed tomography, CT, for acute head trauma and most intracranial pathology. They still retain some utility for specific indications like facial fractures, sinus evaluation, or certain foreign bodies, but their role has diminished significantly. This evolution reminds us that while radiography is powerful, it is but one tool in the ever-expanding toolkit of medical imaging. As we've traversed these anatomical landscapes, I hope you've come to appreciate not just the science, but the profound artistry involved in radiography. The radiographer, much like a sculptor, carefully positions the patient, adjusting angles, distances, and exposure factors to coax the most informative image from the invisible X-ray beam. Their deep understanding of human anatomy, coupled with a nuanced grasp of physics, allows them to anticipate how different structures will appear and how best to unfold them from the inherent superimposition of a 2D image. Each projection is a deliberate choice, a specific question asked of the body. Is there a fracture? Is the lung clear? Is the bowel obstructed? The clarity of the answer depends directly on the skill and thoughtful precision of the radiographer. They are the silent architects of these shadow maps, ensuring patient comfort, minimizing radiation dose, and ultimately providing the critical visual information upon which diagnoses are made. We have now journeyed through the fundamental radiographic appearances of the body's main regions, learning to decipher the basic stories told by X-rays. Yet, as our exploration of the skull hinted, the very nature of 2D imaging, projecting a three-dimensional reality onto a flat plane, has its inherent limitations. We still grapple with superimposition, with the loss of depth. This leaves us with a compelling question. Can we move beyond these flat, two-dimensional shadows? Can we find a way to peer through the layers to reconstruct the body's internal architecture in its full, glorious three-dimensional form? Indeed, we can. And that, my friends, is the wondrous frontier we shall explore in our next contemplative session. Until then, carry these images in your mind, these profound insights into the unseen world within us. Welcome back, dear friends, to our quiet sanctuary of discovery here at Dreamy Academy. As the echoes of our last session gently fade, a profound question lingers in the air, a whisper that beckons us deeper into the unseen realms of the human body. Can we move beyond these flat, two-dimensional shadows to reconstruct the body's internal architecture in its full, glorious three-dimensional form? Indeed, the world of conventional radiography, with all its foundational brilliance, presents us with a beautiful yet inherently limited perspective. We've learned to interpret the intricate dance of light and shadow, the subtle gradations of grey that paint a two-dimensional map of internal structures. We've become adept at discerning air from bone, fat from soft tissue, and even recognizing the telltale signs of pathology within these superimposed layers. Yet, as we discussed, the very nature of projecting a three-dimensional object onto a two-dimensional plane inevitably leads to superimposition, where structures overlap, obscuring details and loss of depth, where the true spatial relationship between organs remains an educated guess, requiring multiple orthogonal views to even begin to piece together the puzzle. Imagine for a moment trying to understand the full complexity of a bustling city by looking at a single aerial photograph. You see buildings, streets, parks, but you cannot truly discern the intricate pathways within a skyscraper, the hidden alleyways, or the precise elevation of one structure relative to another. You crave depth, layers, the ability to peel back the surface and explore within. This very yearning for depth, for the complete, unadulterated spatial understanding of the body's interior, gave rise to a revolutionary leap in medical imaging, a leap that transformed our flat shadow maps into vibrant, multi-dimensional blueprints. This, my friends, is the realm of computed tomography, or The very word tomography itself is a poetic blend of Greek origins, tomos meaning slice or section, and graphein meaning to write. Thus, tomography is literally to write in slices. It's a concept that liberates us from the constraints of a single encompassing view, allowing us to meticulously dissect the body's volume, slice by infinitesimal slice, and then reassemble these pieces into a breathtakingly detailed three-dimensional whole. The story of CT, like many great scientific tales, is one of brilliant minds and persistent innovation. It was in the early 70s that Sir Godfrey Hounsfield, an electrical engineer, and Alan Cormack, a physicist, independently developed the theoretical and practical foundations for what would become CT. Their work, which earned them a Nobel Prize, ushered in an era where the unseen became not just visible but quantifiable in 3 dimensions. So how does this magic unfold? Picture our familiar X-ray tube, the very heart of conventional radiography. Now, imagine it not as a static emitter, but as a dynamic explorer. In a CT scanner, the X-ray tube, along with an array of sophisticated detectors on the opposite side, rotates rapidly around a patient who lies gently on a moving table. This continuous rotation means that instead of just 1 or 2 views, the X-ray beam passes through the body from hundreds, sometimes thousands, of different angles as it completes a full 360-degree sweep. Each tiny pulse of X-rays, emanating from a slightly different angle, penetrates the patient's body and is attenuated by the various tissues it encounters. The detectors then capture the intensity of these attenuated X-rays. Think of it as taking countless photographs, each from a unique vantage point around the subject. But these aren't just photographs. They are precise measurements of X-ray absorption along myriad paths. Now, here's where the computed part of computed tomography truly shines. This deluge of data, these thousands of individual X-ray transmission measurements from countless angles, is far too complex for the human eye to interpret directly. This is where the mighty hand of the computer steps in. Sophisticated mathematical algorithms, often referred to as back projection or filtered back projection, take this raw data and meticulously reconstruct a cross-sectional image or slice of the body. It's like solving an incredibly intricate puzzle, where each piece of X-ray information contributes to building a complete picture of the tissue density within that specific slice. The output of this computational marvel is not just a flat image, but a precise map of tissue density within that slice. Each tiny point in this reconstructed image represents a voxel, a 3-dimensional volume element, the true spatial equivalent of a 2-dimensional pixel. And for each voxel, the computer assigns a numerical value, a quantitative measure of its X-ray attenuation. These values are known as Hounsfield units, HU. The Hounsfield scale is a fascinating invention, a standardized language for tissue density. At its heart, water is assigned a value of 0 HU. Materials less dense than water, like fat, typically fall into negative HU values, e.g. 50 to 100 HU, while air, being the least dense, is a stark 1000 HU. Conversely, materials denser than water, like soft tissues, have positive HU values, e.g. plus 30 to plus 60 HU, and bone, being the densest natural tissue, can range from 400 HU to well over 1000 HU. Metal, of course, shines even brighter, reaching thousands of HU. This quantitative precision of Hounsfield units is a game changer. It allows us to differentiate between tissues with far greater subtlety than conventional radiography. Where plain X-rays might show a general grey for all soft tissues, CT can distinguish between different types of fluid, subtle changes in organ parenchyma, or even the varying densities within a tumour. It provides a level of detail that was previously unimaginable. The most immediate and profound benefit of CT, as you might already surmise, is the elimination of superimposition. By imaging in thin, discrete slices, we effectively cut through the body, removing the layers that obscure structures in a conventional X-ray. Imagine seeing the intricate network of blood vessels within the lung, or the precise margins of a tumour within the liver, without the overlying ribs or bowel gas interfering with your view. This clarity is transformative, offering an unparalleled view into the body's internal architecture. Furthermore, CT offers superior soft tissue contrast. The ability to differentiate tissues based on their precise Hounsfield units means we can see subtle variations within organs that would appear as a uniform grey on a plain radiograph. This is particularly crucial for evaluating organs like the brain, where different types of tissue, grey matter, white matter, cerebrospinal fluid, have subtle but distinct HU values, allowing us to detect strokes, bleeds, or tumours with remarkable sensitivity. Similarly, in the abdomen, we can differentiate between various organs, detect fluid collections, or identify masses. And here, my friends, we arrive at the answer to our opening question, the true triumph of CT, its unparalleled ability to provide three-dimensional reconstruction. Once hundreds of these individual cross-sectional slices have been acquired, the powerful computer can stack them together like a digital deck of cards, and then render them into a complete volumetric model of the scanned region. This means we can view the body not just in axial transverse slices, but also reformat the data into sagittal side-to-side and coronal front-to-back views, or even rotate the entire reconstructed volume to see it from any angle imaginable. Techniques like volume rendering, VR, multiplanar reconstructions, MPR, maximum intensity projections, MIP, and minimum intensity projections, MIN-IP, allow us to highlight specific structures such as blood vessels in a CT angiogram or air passages in the lungs, creating stunning, detailed 3D models that truly bring the anatomy to life. We move from a shadow map to a virtual dissection, a complete architectural blueprint. The applications of CT are vast and ever-expanding, touching nearly every facet of modern medicine. In sheer trauma, it is indispensable for rapidly assessing severe injuries to the head, chest, abdomen, and pelvis, quickly identifying fractures, internal bleeding, or organ damage. In neurology, CT is often the first line of investigation for acute stroke, brain hemorrhage, or masses. For oncology, it plays a critical role in detecting, staging, and monitoring the response to treatment for various cancers throughout the body. Vascular imaging has been revolutionized by CT angiography, CTA, allowing us to visualize blood vessels, detect blockages, aneurysms, or dissections with incredible detail. In the chest, it is superb for evaluating lung nodules, infections, or pulmonary emboli, and in whole musculoskeletal imaging, especially for complex fractures or intricate joint pathologies. The 3D detail provided by CT is invaluable for surgical planning. However, with great power comes great responsibility, and CT is not without its considerations. While the diagnostic benefits are immense, CT scans do involve ionizing radiation, and typically a higher dose than a single conventional X-ray. This is why the principle of ALARA, as low as reasonably achievable, is paramount, and every CT examination must be carefully justified to ensure the diagnostic benefit outweighs the potential risk. Advances in technology such as iterative reconstruction algorithms and dose modulation techniques are continuously working to reduce radiation exposure while maintaining diagnostic image quality. Another consideration is the cost and accessibility. CT scanners are sophisticated, expensive machines, and while their availability has increased dramatically, they are not as ubiquitous as basic X-ray units. Furthermore, for many CT studies, particularly those involving vascular structures or requiring enhanced visualization of organs, an iodinated contrast medium is administered intravenously. This contrast agent temporarily increases the X-ray attenuation of blood vessels and certain tissues, making them stand out more clearly. While generally safe, there are potential risks associated with contrast, including allergic reactions or kidney impairment, which necessitate careful patient screening and monitoring. Even suboptimal patient motion, though less of an issue than in the past due to rapid scan times, can still degrade image quality. The role of the radiographer in CT is one of immense skill and precision. They are the architects of the scan, responsible for meticulous patient preparation, accurate positioning, safe administration of contrast media, and the technical execution of the scan itself. Their understanding of anatomy, pathology, and scanner protocols ensures that the right images are acquired with optimal quality and minimal radiation dose, providing the diagnostic information that is so critical for patient care. It is a blend of scientific knowledge, technical expertise, and compassionate patient interaction. As we conclude our journey through the revolutionary world of computed tomography, we have truly witnessed how the once elusive third dimension has been unveiled. We have moved beyond the limitations of flat shadows to explore the body's internal architecture in its full, glorious, and quantifiable volumetric form. Yet, even with this incredible leap, the symphony of medical imaging continues to play, with other instruments, other frequencies, waiting to reveal different facets of the unseen. Our exploration, dear friends, is far from over, for there are still more wonders to discover, more depths to plumb, and more quiet truths to uncover in the vast invisible landscape within us. And so we journey together through the luminous shadows of X-rays, charting the body's architecture in 2 dimensions, then soared into the intricate cross-sectional world of computed tomography, where the very fabric of our being was meticulously reconstructed in 3-dimensional detail. We witnessed how each modality, born of scientific curiosity and technological ingenuity, offered a unique lens into the unseen, each with its own language of light and shadow, density and attenuation. But the universe of medical imaging, my dear friends, is far vaster and more wondrous than even the most powerful X-ray beam or the most sophisticated CT scanner can reveal alone. We stand now at a new threshold, poised to explore a realm where the very atoms within us become instruments in a silent magnetic symphony, revealing secrets whispered not by energetic photons, but by the subtle dance of subatomic particles. Imagine, if you will, stepping away from the bustling X-ray-filled corridors of our previous explorations. We enter now a different kind of chamber, one often described as a portal to another dimension, a dimension of profound stillness, yet immense power. This is the realm of magnetic resonance imaging, or MRI. And here we encounter a fundamental shift, a departure from the ionizing radiation that has been our companion thus far. For in MRI we harness not X-rays, but the very forces that govern our planet and the cosmos, magnetism and radio waves. Think of it for a moment not as shining a light through the body, but as listening to the body itself sing. A deep resonant hum, unique to each tissue, each cell, each molecule. This is the magic of MRI, a technology that allows us to peer into the softest, most delicate tissues with unparalleled clarity, to distinguish between the various shades of grey matter in the brain, to visualize the intricate network of nerves, tendons and ligaments that hold us together, all without a single X-ray photon. How does this profound magic unfold? Let us embark on this new adventure, a patient and thoughtful exploration into the heart of MRI. At the core of MRI lies a principle both elegant and astonishing: the manipulation of the most abundant atom in our bodies, hydrogen. Our bodies, as you know, are largely water, and water, H2O, is rich in hydrogen atoms. Each hydrogen atom possesses a single proton in its nucleus, and this proton, my friends, is a tiny spinning magnet. Think of it as a minuscule compass needle constantly twirling, possessing a north and south pole. Normally, these countless billions of tiny compasses within your body are oriented randomly, pointing in every conceivable direction, like a chaotic crowd. Now, imagine entering the MRI scanner. This is no ordinary machine. It houses an incredibly powerful magnet, many thousands of times stronger than the Earth's magnetic field. As you gently glide into this magnificent instrument, a profound transformation occurs. This colossal magnetic field, which we call the main magnetic field, B0, acts upon all those randomly oriented hydrogen protons. Like an invisible guiding hand, it coaxes them gently but firmly to align themselves with its own powerful force. Most will align parallel to the main field, a few will align anti-parallel, but the net effect is a slight majority aligning with the field, creating a net magnetization within your body. Suddenly, those chaotic compasses are standing in formation, facing a common direction. This is the first silent act of the MRI symphony. With our protons now aligned, poised and ready, the next step in our magnetic dance begins. The MRI scanner then emits sharp, rapid pulses of radio frequency, RF, energy. Think of these RF pulses as a specific musical note, precise frequency, designed to resonate only with our aligned hydrogen protons. When this song is played, these protons absorb the energy from the RF pulse, much like a tuning fork vibrating when struck. This absorbed energy causes them to temporarily tip away from their alignment with the main magnetic field. They are for a brief moment knocked out of their synchronized formation, dancing to the tune of the radio wave. But this dance is fleeting. As soon as the RF pulse is turned off, the protons, eager to return to their natural state of alignment with the powerful main magnetic field, begin to relax. As they relax, they release the absorbed energy, much like our tuning fork gradually stops vibrating, emitting its own soft hum. This emitted energy is also in the form of radio waves, and it is this faint, unique signal, this whisper from the protons, that the MRI scanner's antennae detect. The beauty, and indeed the genius of MRI lies in how these protons relax and what their whispers tell us. Different tissues in the body, fat, water, muscle, brain tissue, have different magnetic properties. They contain varying concentrations of hydrogen protons, and these protons are in different molecular environments. Consequently, they relax at different rates, both in terms of how quickly they realign with the main magnetic field, T1 relaxation, and how quickly their spins lose coherence, T2 relaxation. Imagine two different types of instruments in our proton orchestra. One might have a short, sharp decay after the note, while another might have a long, lingering echo. By carefully timing when it listens for these echoes, the MRI scanner can distinguish between these different relaxation rates. It's like listening to the subtle differences in timbre and sustain between a piano and a violin, even if they play the same note. These differences in T1 and T2 relaxation times are what give MRI its unparalleled ability to differentiate between various soft tissues, painting a picture with exquisite contrast. But how does the scanner know where these whispers are coming from within your body? This is where another set of ingenious components called gradient coils come into play. These coils create smaller secondary magnetic fields that vary linearly across the body. Think of them as subtly altering the pitch of our proton symphony across different sections of the body. By knowing precisely how these gradient fields are applied and how they affect the frequency of the emitted signals, the computer can pinpoint the exact location of each proton's whisper in 3 dimensions. It's like having a conductor who can not only hear every instrument, but also knows the precise position of every musician on the stage. All these detected signals, these myriad whispers, are then sent to a powerful computer. This computer acts as our master interpreter, taking the complex tapestry of radio signals, processing them with sophisticated algorithms, and reconstructing them into the detailed cross-sectional images we see. These images, unlike the density-based Hounsfield units of CT, reflect the unique magnetic properties and relaxation times of the tissues, offering a completely different, yet profoundly insightful perspective. The result, my friends, is nothing short of breathtaking. Where CT excels at bone and acute hemorrhage, MRI shines in its ability to visualize soft tissues with extraordinary clarity. We can see the intricate folds of the brain, differentiating grey matter from white matter, detecting subtle lesions, tumours or areas of inflammation that might be invisible on other modalities. We can explore the delicate structures of the spinal cord, identifying nerve impingements or disc herniations, the complex architecture of joints, ligaments, tendons, cartilage and muscle is laid bare in stunning detail, making MRI indispensable for musculoskeletal injuries. We can even visualize the flow of blood without the need for contrast in many cases, or peer into the beating heart, capturing its dynamic motion. One of the most remarkable advantages of MRI, and a significant departure from X-ray based imaging, is its inherent multiplanar capability. Because the data is acquired volumetrically, the computer can reconstruct images in any plane: axial, cross-sectional, sagittal, side to side, coronal, front to back, or even oblique angles, without ever having to reposition the patient. This flexibility allows clinicians to view anatomy from the most advantageous perspective, enhancing diagnostic confidence. And perhaps the most comforting aspect of this magnetic magic, it uses no ionizing radiation. This makes MRI a particularly valuable tool for patients who require multiple imaging studies, for children, and for pregnant individuals, where the cumulative effects of radiation exposure are a significant concern. However, such profound power comes with its own set of considerations, and it is important to approach MRI with a deep understanding of its unique requirements. The most prominent of these is the incredibly strong magnetic field itself. This field is always on, even when no imaging is being performed. Therefore, strict safety protocols are paramount. Any ferromagnetic object, pacemakers, certain types of aneurysm clips, metallic implants, even everyday items like keys or credit cards, can be a significant hazard if brought into the MRI suite, potentially causing serious injury or malfunction. Patients with such implants often cannot undergo an MRI. This powerful, silent guardian of the magnetic field demands our utmost respect and caution. Another consideration is the time required for an MRI scan. Unlike the rapt acquisition of a CT scan, MRI sequences can be lengthy, sometimes lasting from 30 minutes to over an hour. This requires patients to lie very still for extended periods, which can be challenging for some, particularly those with claustrophobia. The scanner is also quite noisy, producing loud knocking and thumping sounds as the gradient coils rapidly switch on and off. Thankfully, earplugs or headphones are always provided to mitigate this. Just as with CT, contrast agents can sometimes be used in MRI, typically gadolinium-based compounds. These agents alter the magnetic properties of tissues, enhancing the visibility of certain pathologies, particularly tumours or areas of inflammation. While generally safe, they do carry their own set of considerations, including rare allergic reactions, and in patients with severe kidney disease, a very rare but serious condition called nephrogenic systemic fibrosis. So we have journeyed from the ethereal shadows of X-rays to the intricate quantitative slices of CT, and now to the magnetic whispers of MRI. Each step has revealed a new layer of understanding, a new dimension in our quest to comprehend the inner workings of the human body. We have learned that the invisible spectrum is a vast orchestra, and our imaging modalities are but different instruments, each playing its unique part, revealing different melodies and harmonies within the grand composition of life. Our exploration continues, dear friends, for the world of medical imaging still holds more wonders. We have yet to fully appreciate the dynamic, real-time insights offered by sound waves or the metabolic revelations whispered by nuclear medicine. But for now, let us pause and reflect on the profound beauty of MRI, a testament to humanity's ingenuity, turning the very fabric of our being into a canvas of magnetic artistry, revealing the quiet truths that lie within. Welcome back, dear friends, to our quiet corner of the Dreamy Academy. We have journeyed far together, haven't we? From the enigmatic shadows cast by X-rays, through the intricate cross-sections revealed by CT, to the profound magnetic whispers of MRI that paint the very fabric of our softest tissues. Each step has unveiled a new dimension, a deeper understanding of the human form, an ever-expanding window into the unseen. But as I hinted at the close of our last contemplation, the tapestry of medical imaging is even richer, woven with threads of energy beyond the electromagnetic spectrum and the dance of atomic nuclei. Today we invite you to explore two more remarkable modalities, each with its unique song and story, before we glimpse a field where imaging transcends diagnosis and becomes a guiding hand in healing. Imagine, if you will, a world where sight is not dependent on light, nor on powerful magnets, but on sound. Sound so high-pitched, so acute, that human ears cannot perceive it. This is the realm of ultrasound, a marvel that harnesses the very essence of echoes to paint dynamic, real-time pictures from within. Think of a bat navigating the night, emitting sharp, rapid pulses and listening intently to the returning echoes to form a spatial map of its surroundings. Or consider the sonar of a submarine, sending out acoustic waves to chart the ocean floor. Ultrasound operates on a beautifully similar principle. Instead of light or magnetism, we employ high-frequency sound waves, typically ranging from 2 to 18 MHz, far beyond the reach of our hearing. At the heart of ultrasound technology lies the transducer, a handheld probe that is truly a tiny marvel of engineering. This device acts as both a speaker and a microphone, a sender and a receiver. When placed on the skin, often with a coupling gel to ensure optimal transmission and reception, the transducer emits these inaudible sound waves into the body. As these sound waves encounter different tissues and structures, Boundaries between muscle and fat, the walls of an organ, the surface of a bone, even the delicate flutter of a heart valve. A portion of the sound wave is reflected back to the transducer as an echo. The magic happens in the interpretation of these echoes. The transducer, now in its listening mode, detects these returning sound waves. A sophisticated computer then measures two critical pieces of information: the time it took for the echo to return and the strength of that echo. Tissues that are dense and reflective, like bone, will send back strong echoes very quickly. Tissues that are less dense or fluid-filled will allow the sound to pass through more readily, reflecting weaker echoes or none at all. By processing thousands of these echoes from different angles and depths, the computer constructs a real-time moving image on a screen. This is why we often see the gentle ripple of a fetal heartbeat or the rhythmic contractions of a heart chamber during an ultrasound examination. It's a live, unfolding drama of sound. One of the most profound advantages of ultrasound is its gentle nature. Unlike X-rays or CT, it uses non-ionizing radiation, making it incredibly safe, particularly for sensitive populations like pregnant mothers and developing fetuses. This makes it the cornerstone of obstetric imaging, offering expectant parents their first breathtaking glimpse of their child. Beyond obstetrics, ultrasound is a versatile diagnostic tool. It excels in visualizing soft tissue structures and fluid-filled organs where X-rays struggle. We use it extensively in more abdominal imaging to examine organs like the gallbladder for gallstones, the liver, kidneys, and pancreas. It's indispensable in cardiac imaging, echocardiography, to assess heart function, valve integrity, and blood flow. It can map the flow of blood through vessels using the whole Doppler effect, allowing us to detect blockages or narrowing in arteries and veins, a critical application in vascular studies. Furthermore, its real-time capability makes it invaluable for guiding minimally invasive procedures, such as biopsies or fluid drainages, ensuring precision and safety. Yet, like all tools, ultrasound has its nuances and limitations. Sound waves struggle to penetrate bone or air. This means structures shielded by ribs like the lungs or obscured by bowel gas are often difficult to visualize clearly. Its effectiveness is also highly operator dependent. The skill and experience of the sonographer in manipulating the transducer, understanding anatomy, and interpreting the real-time images are paramount. It is an art as much as a science, demanding a keen eye and a steady hand. Now, let us shift our gaze from the echoes of sound to the subtle emissions of light from within. We move from seeing structure and motion to observing function itself, to understanding the very metabolic activities that define life and disease. This is the fascinating world of nuclear medicine. Imagine for a moment that we could introduce a tiny harmless beacon into the body, a molecular guide that would travel to specific tissues, illuminate their activity, and then gently signal its presence from within. This is precisely what nuclear medicine achieves through the use of radiopharmaceuticals. Special drugs tagged with very small safe amounts of radioactive material. These radiopharmaceuticals are not designed to alter the body, but rather to mimic naturally occurring substances or to target specific physiological processes. For instance, some tracers might behave like glucose accumulating in areas of high metabolic activity, such as rapidly growing tumours or active brain regions. Others might bind to specific receptors on cells or travel to the heart muscle to assess its blood supply. Once introduced into the body, these tracers emit tiny packets of energy called gamma rays as they decay. The magic here lies not in sending energy into the body and receiving reflections, like X-ray, CT, or ultrasound, but in detecting the energy that is being emitted from within the body. Specialized cameras, known as gamma cameras, for SPECT, single photon emission computed tomography, or PET scanners, positron emission tomography, are designed to detect these gamma rays. These cameras do not produce an anatomical image in the way an X-ray or CT does. Instead, they create a functional map showing where the radiopharmaceutical has accumulated and, by extension, how active certain tissues or organs are. The insights gained from nuclear medicine are profound. It allows us to detect diseases often at their earliest stages, sometimes even before anatomical changes become visible on other imaging modalities. In oncology, PET scans, often combined with CT, PET-CT, are invaluable for staging cancer, detecting metastases, and monitoring treatment response by highlighting metabolically active tumor cells. In cardiology, nuclear stress tests assess blood flow to the heart muscle, identifying areas of ischemia or damage. In neurology, these scans can evaluate brain function, aiding in the diagnosis of conditions like Alzheimer's disease, Parkinson's disease, or epilepsy. The advantages are clear: unparalleled insight into physiological processes and the ability to detect disease at a molecular level. However, nuclear medicine also presents its own set of considerations. It does involve ionizing radiation, albeit in carefully controlled and generally low doses, requiring adherence to the ALARA principle, as low as reasonably achievable. The spatial resolution, or the fine detail of the image, is generally lower than that of CT or MRI, meaning nuclear medicine images are often fused with anatomical images from other modalities to provide a complete picture. Furthermore, these procedures require specialized facilities, radiopharmacies, and highly trained personnel. As we conclude our exploration of distinct imaging modalities, I want to briefly introduce you to a captivating and rapidly evolving field where these diagnostic tools transcend their traditional role and become direct agents of healing. Interventional radiology. Imagine a surgeon performing a delicate procedure, not with a large incision, but with a tiny needle or catheter, guided by the precise real-time vision of an imaging screen. This is the essence of interventional radiology. It is a subspecialty of radiology that utilizes various imaging techniques, most commonly fluoroscopy, live, moving X-ray, but also CT and ultrasound, to guide minimally invasive procedures directly within the body. The interventional radiologist, often working alongside a highly skilled technologist, performs procedures that once required open surgery, but now through a small puncture in the skin. Think of it, treating a blocked artery by guiding a catheter in a tiny balloon or stent through blood vessels, dissolving a clot, performing a biopsy of a deep-seated tumor, draining an abscess, or even delivering targeted chemotherapy directly to a tumor. The benefits are transformative. Reduced pain, smaller scars, shorter hospital stays, and faster recovery times for patients. It is a testament to the power of our imaging journey that these visualizations have moved beyond mere diagnosis to become the eyes and hands of therapeutic intervention. It is a field that demands not only a profound understanding of anatomy and imaging physics, but also exceptional manual dexterity and clinical acumen. And so, dear friends, our adventure through the landscape of medical imaging science has brought us to this magnificent vista. We have traversed the spectrum from the stark shadows of X-rays to the functional glow of nuclear medicine, from the intricate 3D maps of CT to the whispered secrets of MRI and the live echoing symphony of ultrasound. We have seen how each modality offers a unique perspective, a different lens through which to observe the wonders and challenges of the human body. This journey, I hope, has instilled in you a deeper appreciation for the ingenuity of human endeavour and the profound beauty that lies hidden within us all. It is a field constantly evolving, driven by curiosity, precision, and an unwavering commitment to understanding and healing. As we pause here, contemplating the vastness of what we have learned, I invite you to carry this sense of wonder forward, knowing that the exploration of reality, seen and unseen, is an endless and most rewarding pursuit. Thank you for joining me on this thoughtful adventure. As we journeyed through the realm of interventional radiology, we glimpsed the pinnacle of this diagnostic evolution, where our extended senses not only reveal the unseen, but also guide the very hands that heal. It is a profound testament to human ingenuity, pushing the boundaries from mere observation to active life-saving intervention. But now, having explored each unique instrument in this grand orchestra of medical imaging, let us pause and consider how these diverse modalities do not merely exist in isolation. No, they perform a magnificent coordinated symphony, each playing its vital part to compose a complete and harmonious understanding of the human body. Imagine, if you will, a vast intricate tapestry woven from threads of light, sound, magnetism, and even the subtle whispers of atomic decay. Each imaging technique we have discussed, X-ray, CT, MRI, ultrasound, nuclear medicine, and their application in interventional radiology represents a distinct thread possessing its own colour, texture and strength. Alone, each thread offers a limited perspective, but woven together they reveal patterns, depths and truths that no single strand could ever convey. This, my dear companions, is the power of integration in medical imaging, the collaborative dance of modalities working in concert to unravel the mysteries within us. Consider a patient arriving at the emergency room after a fall. The first swift glance into their body might very well be an X-ray. It's the rapid foundational sketch, offering a quick assessment of bone integrity, perhaps revealing a fracture in a limb or a collapsed lung. The X-ray is the opening note, clear and immediate. But what if the X-ray is ambiguous or suggests a more complex injury? What if it hints at subtle damage to a joint or a fracture that twists and turns in multiple planes? This is where the orchestra swells. The computed tomography CT scan steps forward, offering its unparalleled ability to slice through the body, layer by meticulous layer. The CT can precisely map the intricate geometry of a comminuted fracture, reveal tiny bone fragments, or delineate the extent of internal bleeding with exquisite detail, eliminating the superimposition that limits the X-ray. It adds depth, volume, and quantifiable data, Hounsfield units, to the initial sketch, transforming it into a three-dimensional blueprint. Yet, perhaps the concern shifts from bone to the delicate soft tissues, the ligaments, tendons, cartilage, or even the spinal cord. Hear the gentle resonant voice of magnetic resonance imaging, MRI. Takes center stage. Unencumbered by ionizing radiation, MRI excels where CT and X-ray falter, painting vivid portraits of soft tissue structures. It can reveal the subtle edema of a sprained ligament, the tear in a meniscus, or the compression of a nerve root with a clarity unmatched by any other modality. MRI doesn't just show us where something is, it often tells us what it is, distinguishing between fluid, fat, muscle, and various pathologies with breathtaking precision. thanks to its sensitivity to water content and molecular environments. And what about the dynamic, living processes, the flow of blood, the rhythmic beat of a heart, or the subtle movements of a developing fetus? For these, the immediate real-time vision of ultrasound becomes indispensable. It is the spontaneous improvisation, the immediate response. Using high-frequency sound waves, ultrasound allows us to watch in motion the valves of the heart, the peristalsis of the bowel, or the gentle flutter of a baby's heartbeat. It is the first line of investigation for gallbladder issues, kidney stones, and gynecological concerns, offering a safe, non-ionizing window into the body's fluid-filled and soft tissue realms. It guides biopsies, drains fluid collections, and monitors progress in a way no static image ever could. Then, for those enigmatic questions about function, about metabolic activity, about the very biological processes at play, nuclear medicine enters with its profound insights. Where other modalities show us anatomy, nuclear medicine shows us physiology. Through the judicious use of radiopharmaceuticals, we can trace the path of glucose uptake in a tumour, PET-CT, assess blood flow to the heart, or evaluate the function of a thyroid gland. It can detect disease at a molecular level, often before anatomical changes become visible on other scans. It is the subtle detective revealing the disease's metabolic fingerprint, guiding treatment strategies, and monitoring therapeutic response. Often these functional insights are fused with anatomical images from CT, as in PET-CT, to provide both location and activity, blending form and function into a single comprehensive image. And in the hands of an interventional radiologist, these instruments are not just for diagnosis, they are tools for precise action. Guided by fluoroscopy, real-time X-ray, ultrasound, or even CT, they navigate the body's intricate pathways, delivering therapies with minimal invasion. They might use fluoroscopy to guide a catheter to unblock a vessel, ultrasound to place a drain, or CT to precisely ablate a tumour. Here, the symphony culminates in a harmonious blend of diagnostic prowess and therapeutic grace. The wisdom lies not in declaring one modality superior to another, but in understanding their unique strengths and limitations, and in orchestrating their use in a logical, patient-centered diagnostic pathway. It is the clinician, often in consultation with the radiologist, who acts as the conductor, choosing the right instrument or combination of instruments to answer the specific clinical question at hand. This integrated approach ensures that we gain the most comprehensive, accurate, and timely understanding of a patient's condition, leading to the most effective care. As we delve into these powerful technologies, a crucial consideration inevitably arises: patient safety. While the benefits of accurate diagnosis and targeted therapy are immense, we must never lose sight of the responsibilities that come with wielding such potent tools. For modalities like X-ray, CT, and nuclear medicine, which rely on ionizing radiation, the principle of ALARA, as low as reasonably achievable, is our unwavering guide. ALARA is more than just an acronym. It is a philosophy, a commitment to minimizing radiation exposure while still obtaining the necessary diagnostic information. It encompasses a range of practices. Justification: ensuring that every imaging request is clinically necessary and that the anticipated benefits outweigh the potential risks. We do not image simply because we can, but because we must. Optimization: using the lowest possible radiation dose settings for each patient, tailored to their size and the specific clinical question. Modern X-ray and CT scanners employ sophisticated dose reduction techniques, such as iterative reconstruction algorithms, which can dramatically reduce dose without compromising image quality. Shielding. Judicious use of lead shielding to protect radiosensitive organs, like the thyroid or gonads, when they are not part of the area of interest. Collimation. Precisely narrowing the X-ray beam to expose only the region of interest, preventing unnecessary scatter and dose to surrounding tissues. For modalities like MRI and ultrasound, which do not use ionizing radiation, different safety considerations come into play. MRI, with its powerful magnetic fields, necessitates rigorous screening for metallic implants or foreign bodies, which can be dangerous or interfere with image quality. The loud noises generated during an MRI scan require hearing protection, and the confined space can induce claustrophobia, requiring compassionate patient care and sometimes sedation. Ultrasound, while generally considered very safe, still requires trained operators to ensure proper use of acoustic energy, especially in sensitive applications like fetal imaging. The balance between diagnostic necessity and patient safety is a delicate one, a constant ethical and scientific endeavour. It is a testament to the dedication of radiographers, radiologists, and medical physicists who work tirelessly to ensure that these powerful tools are used wisely and safely, maximizing benefit while minimizing risk. And what lies beyond our current horizon? As we stand at this fascinating juncture, having journeyed through the past and present of medical imaging, we can't help but gaze forward, contemplating the future of this ever-evolving field. The pace of innovation is breathtaking, promising even more profound ways to peer into the human body. One of the most significant forces shaping tomorrow's imaging landscape is artificial intelligence, AI, and machine learning. Imagine algorithms that can sift through vast datasets of images, identifying subtle patterns invisible to the human eye, assisting in the early detection of disease, or predicting a patient's response to treatment. AI is already beginning to optimize image acquisition protocols, reduce scan times, and enhance image quality. It's not about replacing the human element, but rather augmenting our capabilities, freeing up radiologists to focus on the most complex cases and patient interaction. Think of it as an incredibly intelligent, tireless assistant, enhancing our vision and analytical power. We are also seeing advancements in molecular imaging, moving beyond the capabilities of current nuclear medicine. New radiotracers are being developed that can target specific cellular receptors or pathways, offering even more precise insights into disease at its earliest, most fundamental stages. This will undoubtedly contribute to the era of personalized medicine, where imaging helps tailor treatment specifically to an individual's unique biological makeup and disease profile. The push for miniaturization and portability continues, with devices like point-of-care ultrasound becoming increasingly sophisticated and accessible, bringing diagnostic capabilities directly to the patient's bedside or even to remote locations. Imagine a future where diagnostic tools are even more integrated into our daily lives, providing proactive health monitoring. Furthermore, technologies like virtual reality (VR) and augmented reality (AR) are beginning to transform how we interact with medical images. Surgeons can practice complex procedures on 3D holographic representations of a patient's anatomy derived from CT or MRI scans. Radiologists might navigate through a virtual body, manipulating images in a truly immersive environment, enhancing understanding and collaboration. This journey, my friends, is far from over. It is a continuous quest, driven by curiosity, compassion, and an unwavering commitment to understanding the intricate miracle that is the human body. From the humble X-ray to the sophisticated fusion of AI and molecular imaging, we are forever extending our senses, pushing the boundaries of what is seen and what is known. It is a testament to the profound beauty of science, interwoven with the quiet truth of human care, guiding us ever deeper into the heart of reality.